talk will cover two broad areas. The first is some thoughts about the nature of both evidence and evaluation. And the second one is a description of some of the work that has been done at Peel Public Health Department on the issue of evidence-informed decision making. I will conclude with some of the lessons that we have learned. Let's start by considering how we make decisions. Decisions tend to be about programs, policies, or operational decisions. And often in government, it's said that they are driven by crises, hot issues, and the concerns of organized interest groups. Here I've listed 6 I's, which show some of the input into how decisions are made in practice. I want to talk particularly about ignorance. This is, although it sounds pejorative, is really just about an absence of information. In reality, we often have to make decisions, even though the information is imperfect. And where I say impatience, that's a recognition that in the real world, we often have to make decisions very fast, and there isn't enough time to gather all of the information together. The reference to inertia reflects that it is often very difficult to change, and it's much easier to carry on doing what we have been used to do. I think everybody wants a better way to make decisions. We're looking for a simple solution combining evidence of effectiveness with evaluation of existing programs or policies and looking for clear, actionable results. The problem is that such a solution will not be simple. This is not an impossible dream and can be done, but not without effort and never perfectly. Let's consider what we mean by evidence. It can be defined as the available body of facts or information indicating whether a belief or proposition is true or valid. This definition would apply to evaluation and to the comprehensive, quality-assured body of facts generated by empirical research. And that's what we usually call evidence. On this slide, we can see that evaluation answers the question, did it work? So as we go from action to the outcome, we can evaluate that process to see if the action produced the desired outcome. Similarly, using evidence to decide what action to select to produce the desired outcome, or to look at possible outcomes of an intervention, constitutes what we commonly call evidence answering the question, can it work? Thus, evidence and evaluation overlap, and often we in fact learn by doing. We use evaluation to contribute to the overall body of knowledge and then infer from that the evidence we need to take further action. A good example of this would be the efforts in tobacco control over the last several decades in public health, where we have evaluated the impact of policy interventions, and that has then constituted the evidence base. We can also look at evidence-informed decision-making this way. And here we have made an analogy with clinical decision-making based on the work of Sir Muir Gray in the UK. When a physician or other provider sees a patient, he hears the patient's condition, assesses this through a history and examination, but also refers to a body of knowledge. This is a form of pattern recognition. From this, options are developed, and then the patient's values, what the patient would like to do, is taken into consideration in arriving at a decision between the healthcare provider and the patient concerning the therapy to be selected. Here we have a similar process, but in this case we are talking about decision making for population-based interventions. Instead of the history and physical of the patient, we have what I've termed information of the instance. That is to say, what are the facts of the case? What is happening now? And we can get this from health status information or from surveillance. Similarly, we have access to a store of generalizable information which is based on, generally, on research. From these we draw conclusions, and these will tell us what the consequences of a particular action will be. But only when we include other drivers of the decision will we arrive at the decision. In other words, there are two stages. In the first stage, the question we are answering is, what will be the consequence of a particular action? The second type of decision is, what should be our policy or program? So what are these drivers or other factors that we take into consideration at arriving at a decision about a policy or program? I've listed some of them here, but obviously there are any number of different factors that are taken into consideration. I will not go through all of these drivers, but you can see that some of the common ones would be stakeholder interests, government priorities is very important. A decision may seem obvious, but if there is no appetite for taking it on, then it will not happen. Public opinion is important, and values, and this can be either ethical values, or it can simply be, how do we rate the value of the outcome compared to other outcomes in which we are interested. Now, I've spoken about evidence, but what is that evidence about? Of what is it evidence? The most obvious one is whether or not an intervention works. In other words, we are talking about, can it work? That is to say, efficacy, or does it work in reality? Effectiveness. We may also want to know about the equity of the decision, that is, how the benefits and risks are distributed. And we also need to know in what circumstances does it work, is it acceptable and feasible at that time, and this of course may vary over time. And is the capacity available to undertake this intervention? And lastly, is it worth doing? In other words, the cost effectiveness. There are other questions we may wish to answer. In reality, we may not be introducing a program in an all or nothing fashion, but deciding whether to increase or reduce in investment. We would therefore need to look at incremental and marginal benefits and marginal costs. I should also speak of what's labeled here as effective dose. Very often we use evidence from experience elsewhere. It's very important that the intensity of the program we wish to put in place reflects that of the program which has provided our evidence if we wish to achieve similar results. Therefore, taking a program which is described in the literature, which is very intense, and then devoting to it only a small portion of those resources. Similarly, when using evidence from elsewhere to arrive at decisions, we need to take into account the risk status of the population on which the study was performed. Many studies are done on very high-risk populations. An example would be decades ago, a lot of work was done on prenatal supplementation in order to reduce low birth weights. Much of this work was done in countries like Guatemala. One would expect dramatic results in those circumstances, but very much less when these are put into place in the Canadian situation. Other attributes of the population, such as its ethnocultural makeup, also need to be taken into consideration. And lastly, the issue of fidelity. The intervention that we put into place, if it is not the same as the intervention described in the literature, may not achieve similar results. So attention should be paid to fidelity to the originally described program. I have mentioned that often we have to take decisions on the basis of very little evidence. We should recognize that even when evidence is available, it may be of poor quality. Literature may describe little about the context of an intervention. Very often there is little information on the kinds of complex interventions which are the reality in health promotion today. We know that we have to have multifactorial and complex interventions, yet it is the nature of science that a reductionist approach is often taken in order to study the individual components of interventions. It is also true that what gets evaluated is very often small programs with small evaluations, and there is an emphasis on programs and much less information on the outcomes of policy interventions. Often the outcome measures are inadequate. Instead of being able to look at the impact of an intervention on health status, we may be presented with information solely on whether the participants liked the program, for example. Lastly, we often have to grapple with very poor definition of the program in the published literature. So we have to ask the question, and the literature purports to answer the question of, does it work, yes or no? But we're also concerned with what it is, and very often there is very poor description of the intervention that was applied. I will now provide a brief description of work that is being done at the region of Peel in Ontario on evidence-informed decision-making in public health. This is one instance of work in which there is a growing interest within public health departments across Canada, and each of them taking slightly different approaches. I'll start with an anecdote. A few years ago in our health department, we wished to promote breastfeeding, and it was thought that one way to do this was to present information about the disadvantages of formula feeding. A public communications campaign was devised, and the creatives for 3 posters had already been developed. And the one we have here is Formula No Thanks, I've got a test to study for. And this is relevant to the issue of intellectual development and whether formula feeding impairs the intellectual development of infants. Just at the time we were ready to launch the program, we decided that we were uncomfortable with this information and that we would search the literature and attempt to synthesize it to see if in fact this was the case. In the case of the impact of formula feeding on intellectual development, we in fact found no evidence whatsoever to support this contention, and this one of the 3 posters was pulled at the last minute. However, many health departments still have on their website information that there is an impact on intellectual development. Here are the other 2 posters concerning formula feeding. One concerning the impact on weight gain and implications for obesity later in life, and the other concerning infection and immunity. And in both of these cases, the literature could provide evidence that these were in fact the case. These 2 posters went ahead. Our experience with evidence and formula feeding occurred at a time when we were considering the issue of the use of evidence in public health practice. Therefore, we undertook to write into our new strategic plan evidence-informed decision-making as a priority initiative. We were fortunate to have support not only from senior staff within the public health department but elsewhere in the organization. We started with using an organizational readiness tool from the Canadian Health Services Research Foundation to assess the state of readiness for change, and recognizing that change was all important, not only change but our reaction to change, and also to document the baseline so that we could study our progress. We undertook a number of focus groups with staff to understand their knowledge and their readiness to undertake this new venture. We recognized that we were not starting from scratch, and that our use of evidence in our organization and in public health generally was not new. However, we recognized that there were some limitations. Awareness of the issue was limited to only a few staff, and most of all, our use of evidence was inconsistent with no quality assurance. For example, there would be cherry picking of literature from the evidence base in order to back up a decision that had already been made. We also recognized that we lacked the infrastructure, such as means of accessing full text articles and of searching databases in order to do comprehensive searches of the literature. A postdoctoral student who was working with us at this stage described our use as evidence as unclear, inconsistent, unsystematic, unstructured, implicit, incomplete, and underdeveloped. You can see one of the comments that she elicited from participants on the previous slide. Are we doing this because it's broken? No, we're doing this because we could be even better. It's the spirit of continuous improvement. We have learned that very few public health departments, certainly not our own, would have the resources to undertake this initiative without help. We were fortunate in that we had a number of people who have assisted us in this initiative. They include the Faculty of Nursing at McMaster University, the Effective Public Health Practice project, also at McMaster, healthevidence.ca, the National Collaborating Center for Methods and Tools, also at McMaster. And we have also used the Executive Training for Research Application, or EXTRA program, of the Canadian Health Services Research Foundation. This slide is a high-level overview of the essentials that require to be put in place to implement a program of evidence-informed decision-making in public health. And these are fairly obvious. First of all, staff require to have the skills to undertake evidence-informed decision-making. These will be of two levels. Some staff will be involved in actually undertaking syntheses of one kind or another of evidence, and this is obviously a high level of skill. But everyone who works in public health also requires the skill to understand what evidence is and to be able to find some evidence and understand its quality and to apply it. Secondly, we need tools, and I will describe some of the tools we have acquired or developed in another slide. Thirdly, access to the body of knowledge by means of some form of library services. Fourthly, partners to enable this to happen. And the last, culture change, is undoubtedly the most important. In the spirit of continuous quality improvement, we have to recognize that as a result of reviewing evidence, we will often change what has been done for many, many years. And this is not an exercise in assigning blame, and we have to recognize that very often staff will have personally invested in a program over the course of many years, and changing is often very difficult. Although change and our reaction to change often creates difficulties and does need attention, on the other hand, we were somewhat surprised with the enthusiasm in which our staff engaged in this new venture. Because our resources were and are constrained, it is important that we use our resources most efficiently. moving towards more effective interventions makes better use of resources, and everybody understands this. Staff were keen to acquire new skills, to influence research agendas, to become more involved with academia, and to disseminate their work and enhance their reputation and the reputation of the organization. Major change requires application and resources over an extended period of time. We've committed adequate resources to this initiative and provided leadership, especially through Dr. Megan Mowat, our Associate Medical Officer of Health. We tried to produce early wins so that the process produces actual changes in our range of programs and how we deliver them, so people can see benefits early on, but at the same time emphasizing that getting to the end of this project will require 10 years. I firmly believe that using evidence in how we practice public health is a responsibility of all professionals in public health practice. In a large health department, this is several hundred employees. So achieving this kind of change in a large organization does require a great deal of resources. Also, the reality in public health today is there are many competing initiatives, and the day-to-day delivery of service often leaves very little time for reflection and contemplation, thinking about what we are doing. It is also commonly the case that public health departments do not currently have the resources devoted to accessing information, for example, through library services that are required. Building skills is the most visible impact on the organization. And for example, many of our staff took several days training on appraising evidence. The extra program also provided very valuable help in training the leaders of this initiative. We were also fortunate to acquire services of a postdoctoral fellow and a knowledge broker through McMaster University, and these two helped our staff on a one-to-one mentoring basis to improve their skills. This is a very simple graphic to outline the process of evidence-informed decision-making in public health. Each of these elements requires tools and skills and proceeds in a sequential fashion. First, one must define the question to be answered, then search for the evidence, appraise the quality of the evidence, synthesize the evidence and interpret it, and lastly, assess its applicability before implementing the intervention and evaluating it. Here we have a graphic representation of knowledge and how it is synthesized. It is important to recognize that there are a vast number of studies in the form of journal articles and so on, and this is unfiltered information. Not only do we not know necessarily its quality, but using this is akin to drinking from a fire hose. There is simply too much information. we therefore use a series of syntheses which bring together all of the information, make it usable and improve its quality. But of course, moving up this pyramid requires time and expense. The biggest change we have seen in practice is that our staff now always look for synthesized evidence rather than attempting to use original primary studies. It is important to recognize, however, that there are many different kinds of evidence, and it is important that we use broad input into making decisions about our programs. With complex interventions and complex outcomes, there may be some types of studies which do not find their way into syntheses of the evidence, and we must remain aware of this. Taking this into account, however, we have developed our own rapid review process, which is something that we believe is feasible for a public health department to undertake when making decisions about programs and policies. It starts out with systematic reviews. We find systematic reviews on a topic and appraise their quality. Those systematic reviews which are of sufficient quality become part of the rapid review process, and they are then synthesized. We then look for additional primary studies which have been published subsequent to the last of the systematic reviews of which we have found. And then we put all of this information together. Being able to access the knowledge base is extremely important. Before we undertook this initiative, Peel was typical of many health departments in that it had the use of a library technician only. Most of its resources were in print, with poor access to full text articles and poor access to bibliographic databases. There was a very limited budget. Peel now has 2 professional librarians. There is access to bibliographic databases as well as to databases of syntheses such as NICE, the Community Guide from CDC, healthevidence.ca in Canada. There is membership in a library consortium which provides low-cost access to full-text articles, and there has been extensive training in health information literacy. Having librarians is in fact highly cost effective. We did a small study to test how long our own professional staff took to undertake a comprehensive search of the literature on a given topic. It took between 10 and 15 hours. A professional librarian can find the same information in 20 minutes. The process of making evidence-informed decisions must be systematic, and tools are essential. These tools are available, The National Collaborating Centre for Methods and Tools in particular has a large number of tools available on its website, and also has backup training and consultation on these tools. I would mention particularly the tool for assessing applicability and transferability. After the literature has been reviewed and staff have a sense of the findings, then this information needs to be transformed into a usable form according to local circumstances, and this tool helps. There is also on our own website a compendium of the tools we used, including tools we use for critically appraising the literature, such as those from CASP and healthevidence.ca, and tools we use to assess guidelines. We use Agree2. This slide simply illustrates the complexity of managing this kind of change. Each of these circles represents a component which had to be put into place to ensure the success of the entire initiative. Many of these are described in a recent article in BNC Public Health by Leslie Pearson. Rather than a completely top-down approach, it is important to engage practitioners in this process. Some of our staff started up communities of practice so that they could share their experience. The Critical Appraisal Club, for example, is simply a meeting of those who have been involved in the process over lunch. We have consistently emphasized that the evidence-informed decision-making process is not an end in itself or a theoretical exercise, but does impact our decisions and our programs and policies. The following are some of our first results. Unfortunately, as you can imagine, very often the result of a review is that the available evidence is poor. Either there is not enough evidence, or what there is of poor quality, or it has been poorly synthesized. Nevertheless, there are some interesting results. Our first result is when we looked at a quit and win contest, which is an incentive intervention to assist smokers to quit. Those who intend to quit can register for this contest, and there is a draw to win a car. These have been common across the country for many years. The conclusion of our review was that there was no evidence of the effectiveness of these programs, even though they had been extensively studied. The review process can be used to answer a number of questions. Firstly, as to whether to add a program. A couple of examples are, firstly, immunizing pregnant women in clinics, whereas we had previously referred these to physicians. As a result of a review showing this was safe and effective, we now immunize pregnant women in the clinics. Second example was a provincial recommendation to undertake mandatory food handler training in order to improve food safety. As a result of this, we elected to consider enhancing inspection of food premises, which was shown to be more effective than mandatory food handler training, for which there was no evidence of impact on food safety. It is also possible to use reviews to decide whether to continue a program or service. For example, as a result of a review, we decided to discontinue one-time community screening for cardiovascular disease risk factors. We can also consider whether or not to change or refocus a program, to do things in a different way. As a result of a review, we changed how we communicated with physicians, reducing the use of print and didactic teaching, and considering increasing academic detailing and audit and feedback and interactive sessions. The process can also help in considering changes in recommendations in guidelines and protocols. We, for example, use this to consider our recommendations on vitamin D supplementation for breastfed infants. The partnerships we have developed during the evidence-informed decision-making initiative have now moved beyond synthesizing evidence into collaboration with academics in undertaking both research and knowledge translation. Our experience has been that our academic colleagues are very keen to work with practitioners in undertaking research and knowledge translation. Finally, a few of the lessons we have learned from our own experience in reviewing evidence and evaluating programs. The first is the importance of defining success. We need to know the effectiveness of interventions, but also much more. We need to know whether and how, for whom and under what conditions interventions work. We need to know how they work when they're adopted, as they're implemented, and how as they are maintained. Most importantly, we need to maintain a population perspective in assessing both the literature and our own evaluations. We must choose the right denominator. In public health, the denominator must also always be the population rather than individuals. That means that reach is extremely important. To give one example, a smoking cessation program operated by a health department might reach a few hundred during the course of a year. Even though highly successful with those who receive the intervention, we must ask ourselves, how big is the problem? How many are we reaching with the intervention? And how much of the problem are we preventing? In the case of Peel, we were in fact reaching several hundred people with a smoking cessation intervention, but we have 179,000 people who are smokers. We must consider how we affect the entire population. Making better decisions makes better use of resources. Infrastructure is necessary in the form of training, access to knowledge, tools, protocols, and these require resources, but these are worthwhile investments. But this is not an academic exercise. There must be a commitment to evidence-based action. There must also be a commitment to taking on action based on the results of evaluations. This has been a brief review of One Health Unit's experience in using evidence. In practice, the process is complex, and judgment is required in undertaking evidence reviews and applying the results. The process is far from perfect, but will continue to improve. And if we can shift our scarce resources from less effective to more effective interventions, we believe the result will be better health.